here, record on this computer, and we are recording. So we're going to talk about Shockwave. I can guarantee I know at least one of you in here has seen extracorporeal Shockwave. And I'm guessing it's probably Jesus, because I know he's seen it.
Yeah, I've performed it on a patient before.
Oh, don't tell me that. You've seen it. That's all I'm going to say. That's all I need to hear. Don't say that you performed it. You've seen it.
Don't say it.
So how many of you guys are familiar or have heard of Shockwave before, other than the Transformer? That was a little geek reference too. Anyone else other than Jesus? Okay, that's because it's kind of a new therapy that's out there, and Shockwave therapy in Spain is really popular. Right? Exactly. Yeah, Dr. P really likes it. By the way, that's on top of the whole thing. Shockwave's an up-and-coming therapy that's shown some really, really, really good results. It started off us looking at Shockwave. So the original Shockwave therapy was for patients that had kidney stones, right? So when patients have kidney stones, does anyone know what they do with what the procedure they do with them is called? Other than passing the most painful thing next to birth?
They break them off, right?
They break them up, right. So the kidney stone, right, they send sound waves in. Those sound waves bounce off and kind of break that kidney stone up and make it smaller so it's easier to pass. It's called a lithotripsy, right? So that's literally breaking up stone. So they saw that and they're like, well, hey, you know, what about, could we use that? Same thing with ultrasound, right? We use ultrasound for imaging. Well, what if we change the wavelength of the ultrasound? How will that change the way it works? And then we came up with therapeutic ultrasound, right? So same idea here. We started with this procedure for a medical treatment, and I said, well, how else could this be beneficial? So it's up and coming. I know there are 5 clinics I know in town have Shockwave therapies. And of those 5 clinics, 3 of them are the same company. There we go. I can't think of the word today. It's early. So what is Shockwave, right? So Shockwave, like I said, was introduced about 20 years ago for treatment of kidney stones, right? And even salivary calculi. I can't even imagine having stones in my salivary glands. That just terrifies me. But lately, SWT has been used to treat musculoskeletal conditions. So everyone can see the PowerPoint. I forgot to ask this, right? You can see the PowerPoint.
Yep.
Yeah, we see it.
Oh, okay, good. I used it personally myself, and I've used it on myself as well, but I've also used it on patients and had great results with it. It's a really cool technique, especially for stuff like plantar fasciitis and epicondylitis. The patient may not like the treatment. We're going to talk about why the patient might not like the treatment, but it does some really nice things. So the Shockwave is a sonic pulse characterized by a high peak pressure, right? So sometimes as high as 50 to 80 millipascals, right? And so that doesn't make much sense to you because, well, what's the Pascal? It's a pretty high peak pressure, meaning that sound wave as it's going in is being forced in there pretty quick. It takes less than 10 seconds to reach that peak amplitude, right? And then has a little bit of a low tensile amplitude afterwards. The nice part about it is that life cycle of that wave is a really short life cycle. I mean, it's going to go in, it hits the target it needs to hit, and doesn't then propagate, say, up, if you're doing on the plantar fascia, move all the way up the, tibia, all the way up to the femur and stuff like that. It kind of dies in the area retreating. It's broad spectrum velocity. I always like to tell patients that, this is literally how I kind of tell them how it works. It's very similar to a high pressure ultrasound. So it's going to use sound waves very much like ultrasound, but those sound waves are coming in at a super, super high volume, right? So if you can think of ultrasound as being sound waves, even though it's not a volume that they can hear, the volume is just the force that's pushing them in, right? That's what that peak pressure is. So it's really good at kind of breaking up those tissue adhesions. So this is that kind of nice chart that here, I'm not going to make you test on this. You're not going to become Shockwave specialist based upon this, but there's the book's nice check on this. We're going to move on. High peak pressure of that Shockwave results in a combination of velocity and frequency, right? So you've got the frequency of the sound wave, you get the velocity of it being pushed in or the loudness of it being pushed in, and that causes obviously a cellular reaction, right? The velocity of these waves pass through the medium, generating what's essentially a controlled explosion. So this sounds bad, right? I say controlled explosion. You're like, wow, that sounds fun. Well, I mean, it can be if you're a redneck, controlled explosions are a lot of fun, right? But in this case, the controlled explosion is happening in an area where they have an adhesion or some sort of a problem. Yeehaw, exactly. The energy is then dissipated and reflected at tissue interfaces, and it allows for that kind of whatever stuck together to become loosened again. The pressure disturbance is propagated three-dimensionally due to the sudden rise in ambient pressure. So that means that it's not only hitting the surface of that whatever we're hitting, say if we're saying the plantar fascia, it's not only hitting the surface of that plantar fascia, but it's going to get under and kind of pull stuff off as well. The sudden rise in cell pressure can cause an expansion and contraction with the medium, causing tensile compression and shear stress. It also causes that cavitation. You remember a little bit about cavitation from ultrasound? What is cavitation? Do you remember? Anyone remember that? Do you remember at least hearing it in ultrasound? I know you heard it, because I heard Dr. O'Neill talk about it, so I know you heard it, right? What does cavitation cause in the area, the localized area? You remember? Because we have stable and we have unstable cavitation. We want stable cavitation. This is going to use a little bit more of the unstable side of it, right? So it's going to cause those air bubbles. Do you remember a little bit about that back with ultrasound? Working at that cellular level where you're exciting the mitochondria. And when you excite those mitochondria, it kind of brings in all the healthy healing stuff. And then because of the sound waves, and if you have it on continuous, you can also heat up the area locally. Same idea here, except it's going to cause it at a much more violent effect. So it's going to happen rather quickly. You know, with ultrasound, how long do you normally do an ultrasound treatment for? I heard somebody had an ultrasound as one of their case studies. How long do you do ultrasound for? 7 minutes, right? And that's 8 minutes. 8 minutes is the technical term because that's for, billing unit. It's based upon your ERA and everything like that, right? With Shockwave, treating one little area can be as quick as, 30 seconds, right? So it doesn't take that much. And the good news is you can hit multiple areas in a rapid time period. That's why there's not a lot of reimbursement yet for this, because we haven't decided how to reimburse for this. Is this going to be a one-time thing where, it's an untimed unit? Are we going to do a timed unit? They're still working on that, and the research still is coming out on it. Stresses are usually in the direction of the wave, but the impedance and dampening at the tissue boundaries reflect and refract all that, right? So if we send a sound wave into the body, no matter how that sound wave goes into the body, it's going to hit different tissue in the area that it's hitting, and is going to refract and reflect all over the place, right? That's kind of the idea of an MRI, right? We send those magnetic waves in, they bounce off the tissue, and they give us an image. Same idea here, we're just not getting an image out of it. We're literally causing those waves to propagate around and relieve the problem that's happening in that area. Drastic changes in pressure will cause that cavitation. The resulting collapse of the cavitating bubbles yields those water jets, which is proposed to cause cellular level tissue damage. So understand, so when we're doing this, we are going to do a little bit of damage. This is one thing you have to tell patients when you're doing Shockwave with them. They're usually not going to feel good after it's done. This is why probably it's not a good idea to do the Shockwave at the beginning of the therapy session. Because if you do it at the beginning of the therapy session, what do you think their idea of going through a full therapy regimen after that's going to be? If you say, I'm going to do this modality with you, it's going to hurt. It's probably going to be very uncomfortable. And then afterwards, we're going to do 45 minutes of exercise. Do you think they're likely to do that? Yeah, they're leaving. They're out the door, right? They're like, nope, peace, I'm gone, right? So a lot of times we're going to do that either at the mid-treatment point or maybe a little bit towards the end before we calm them down afterwards, right? But it is uncomfortable. I'm going to tell you that from having experience and having it done, because when I was doing it on patients, one of the first things I've done in the clinic, when I get a new piece of equipment that I'm not familiar with, I want it done on me because I want to feel, it's not really brand new. It's been around for about 10 to 15 years, Tyler. It's just that not a lot of clinics have used it yet because it's kind of still expensive, if that makes sense. And we're slow to adapt things that are expensive. Let's just face it, we kind of are. A lot of clinicians that have gone overseas are ones that bring it back with them and say, this is really awesome. I give a shout out to Suarez Physical Therapy. I know they use it quite extensively, and that's why I know that Jesus has seen it. They use it quite extensively and has a really good effect on the patients that get it.
Seems scary.
What's that?
It seems scary.
Yeah, it is. That's the thing. When I first saw it, I was like, "Oh, this kind of." And so when I felt it for the first time, it's definitely uncomfortable. But you'd be amazed at what happens. They come back the next day and they're like, "Oh my God, I was able to work all day without any pain." So you're going to get a little bit of that. What's that pain relieving effect that we get where we cause them pain to relieve pain? What's that pain relieving model?
Not the noxious? No.
That's it. Yep, you're right.
Okay.
The noxious stimuli, or what's the other term for it? The endogenous.
Pain control?
There is pain control theory. It's the endogenous opioid theory, right? So it's causing the natural relieving pain modulators in the body to be released rather than taking a pain med or something to that effect. So the amount of attenuation and steepening that occurs to tissue boundaries accounts for most of the energy loss. So the different types of tissue what that's saying is the different types of tissue are going to react differently to this modality, right? And the same thing with ultrasound, right? What happens if you do ultrasound with somebody that's got a high adipose content? Are they going to get as much of an effect as someone that's got a lower body fat ratio? Or E-stim even, right? They're not going to get the same similar effect, right? And especially with this one, because again, those sound waves, when they hit that adipose, what's adipose primarily composed of? Fat, yeah. What causes it to kind of swell? What causes the adipose to kind of be, bulge out? So what causes your nice, keg on your stomach? Yeah, liquid, right? It's liquid. Beer too, yes, okay. Right? So adipose is heavy in water content. And we know that sound loves to travel via water. So if you do a high adipose content area with ultrasound or with shockwave, those sound waves are going to spread out a lot farther. You're going to get, do you remember what that thing's called when sound waves stay closer together? It's on the tag of the ultrasound. Do you remember what that's called? Starts with a B. It's not beer. When it either stays nice and columnated or spreads out. You remember beam non-uniformity ratio a little bit? I talked about that in the video that I had done for you guys, and I talked about, right? Where the beam non-uniformity ratio is where the beam tries to stay this way but spreads out because of tissue. Well, if you have a high adipose rate, those waves are going to propagate over a large area and not stay in one generalized area. It's also why sometimes when you have a high adipose content, MRIs aren't always as clear as they could be because, again, those sound waves are going in and they're going to bounce everywhere. Attenuation of shock waves minimized by ensuring contact with transmitting source. So just like ultrasound, you need to have a coupling gel, right? Usually we're just going to use ultrasound gel because we have it in the clinic. But pretty much any lotion, any type of even hydrogel for wounds, anything like that is functional as long as it's going to allow that sound wave to pass without reverberating back up into the sound head, right? That's what we try to avoid with ultrasound, is that sound wave going down, not being able to penetrate through that ultrasound gel and coming right back in and causing unstable cavitation of the crystal. Same idea here. So different types of ways that you're going to see the shockwave generation is going to be electrohydraulic, electromagnetic, and piezoelectric. Which one of those have you guys seen before? I know you saw one of those before, at least. Maybe you might have seen all of them, depending upon what you've done. Piezoelectric, right? Piezoelectric is using that crystal to send a current through it to release sound waves. So really, the shock wave is using all three of these methods to generate that intense wave, right? So electrohydraulic, yeah, right? That's using electricity through water to get pressure, right? Electromagnetic is exactly like it sounds, converting electricity into magnetic waves to propagate the wave. And the piezoelectric, converting electricity through crystal to sound waves. They're going to convert the electric energy with a mechanical shock wave at different volumes and different depths. So this is it's a really neat technique. So again, here's the physical parameters. When you see physical parameters of Shockwave, what you should be thinking in your head is stuff I've got to document. Does that make sense? Same idea. If I said the physical parameters of ultrasound, right? We want to document our duty cycle. We want to document our intensity. We want to document our time, right? We may want to document our sound head size. Same idea here, right? Now, the good news with these machines, because there's a lot of complicated math with these. And it's really, if you actually get into the study of how a Shockwave works, it gets really convoluted. And it's, you know, there's a lot of physics that get involved with it and stuff like that. And that's when you're like, oh my God, my head's going to explode. The good news is most of the machines have everything pretty much touch and play for you. You've got to do plantar fasciitis. You can click down through. It'll ask you for plantar fasciitis, if it's acute or if it's chronic. And it will set these up for you, the parameters, based upon what you choose, right? So if we're going for more of an acute phase, like we would with a patient that's, you know, newly injured with plantar fasciitis, we're probably not going to go as heavy into that causing pain, because we know that we cause pain to those patients, they get a little worse. We're going to go more sensory like we would with E-stim. We're in the chronic phase. It's going to cause a little bit more of a fluctuation in that pulse to cause a little bit of noxious stimuli to go. The total acoustic energy is the entire beam, right? In the sky, it's described as the energy per shock wave. You're usually going to see it either measured in joules or it's going to be measured in watts, depending upon the machine. The most important physical parameter when treating these tissues, right? So what's going to happen? Well, the tensile and shear stresses are going to be created in the direction of the shockwave propagation. So first of all, we have to figure out what we're treating, right? And you know what you're treating. It's going to be the diagnosis. Say we're going to be treating plantar fasciitis. Well, plantar fasciitis is a problem where typically there's going to be some problems with that fascia, which is that nice shiny layer under the skin that allows the tendons, the muscles, and the skin to glide smoothly with one another. Sometimes they get stuck down. Has anyone ever had plantar fasciitis in here? It's not fun. If anyone's ever been a server or worked in a kitchen, I'm sure you've had plantar fasciitis.
Pretty painful.
It's intensely painful. And honestly, it's fun. Or the band, exactly. Yep. All those times at band camp get you plantar fasciitis. Yeah, right. Even high level athletes get it. Right. So that's the thing. And you got to think about it. You know, we've got the perfect industry here in our town to cause plantar fasciitis, because we have people walking around serving drinks or serving food in the most uncomfortable shoes possible, taking their plantar fascia and first of all shrinking it up by having themselves in an extended plantar flexed posture. And there's a lot of servers that suffer from plantar fasciitis. So we have to identify the area that we're going. If we're going to plantar fascia, we want it perpendicular to that plantar fascia, right? Anywhere we're going to go, destroy a couple of your fantasy football teams for sure. If not that, then Lisfranc fractures. So, you know, we're going to send those waves in perpendicular to the area. So if we're doing, you know, lateral epicondylitis, we want it as perpendicular as we can get. So it's going in and reflecting off the tissue we're trying to treat. The tensile forces are greater than the tensile strength of water and generate those bubbles. That's that cavitation, similar to what happens with ultrasound. As those bubbles come up, they're going to collapse, and it's going to create these high energy water jets. That's what's going to stimulate your mitochondria, right? The more we increase fluid retention and energy production in the area, the more the mitochondria gets stimulated. If those mitochondria get stimulated, we know that that brings more nutrients to the area, more nutrients will heal the area. Indirect effect causes tissue temperature and damages cells. So there will be a little damage here, but sometimes, you know, in order to fix things, sometimes we've got to break it a little bit more. That's redneck science right there. If it doesn't get fixed, then duct tape works. Impact of this cavitation water jets is reported to depend strongly on the water content of the tissue and the time between shockwave applications. You're not going to want to do this, and most of the clinics I've worked at, you're not going to want to do this every session. They're not going to want to keep coming back to you if every time you see them, you send them home in pain. And on top of that, there's a lot of studies that show you're going to have a reducing effect the more frequently they get it. So usually it's every third visit or every other visit at best where they're getting this treatment. And just like ultrasound, there are studies that have shown that at the 12 treatment point, what do you think happens with this treatment? Same thing with ultrasound. After that 12 treatment, what do you think happens? I mentioned this briefly about ultrasound, I think in physics. After the 12 treatments of that condition, the body stops responding as well. Yeah, it stops being effective because the body stops responding to it. Because, think about it, right? You walk into an area that's stinky 12 times, eventually that area is not going to be stinky to you. Same idea here, where your body's going to accommodate to it, and it's not going to be as effective. So the same thing with ultrasound. We watch how many times they're going to get it. On bone, now, I'm going to preface this. I've only used this once on bone, and the one time that I used it on bone, it was on a healing fracture, and that patient hated me. Because again, high amplitude sound waves on bone that might be damaged just doesn't sound like a good time. The acoustic streaming causes decavitation and it increases the vascularity and bone regeneration. So it does show, just like ultrasound on pulse, that it does help that callus form and help the healing of the bone tissue. But at this case, we're going to do less than 2,000 pulses. We're doing a very, very short treatment, right? Because what is one way we can figure out if a patient has a bone fracture? What can we do other than an x-ray? What else can we use as a really good diagnostic tool? Touch it, okay, yeah, that'll work too. Ultrasound, okay, could do that too. I'm thinking more simple and more low tech.
Read the chart.
Read the chart, okay. Tuning fork, I heard it, somebody said it. There we go, the tuning fork, right? Tuning fork works on frequency, right? How do you know if a patient has so you ring the tuning fork, you put it on the bone that you think is broke. How do you know if it's broken?
They scream.
Yeah, they scream or punch you. Yep. True story. I've dodged a few. Mainly because the PT's like, hey, can you test that femur for me? And they're sitting across the room. Ding, poof. Oh, yeah, it's broken. Thanks. Glad you tested it for me. Not all PTs are like that, but I actually did have PT that used to do stuff like that. It was kind of funny. I've learned really quick. But if you think about it, if you're sending these continuous high pulses into that area, there's going to be a time where it's actually going to break it down more than heal it. So we're going to do a little bit on bone. Tendons, same idea with shock waves, right? Or with ultrasound, the shock waves are going to increase the biological stress effect on the tendon. It's going to bring it off of the bone a little bit. So that's going to allow it to pull up, and especially if you got something like epicondylitis where everything's kind of stuck down and not moving and you have some adhesions, it'll cause shear failure. So I'll allow it to kind of break up a little bit. That's going to allow collagen to come in. You're going to go through the normal healing effect, your normal cycle of going through inflammation, and all your proliferation, remodeling, maturation, everything like that in the area, especially if an area is stuck, right? If they've gotten stuck in that inflammation phase. Most of the patients that have chronic epicondylitis get stuck in inflammation. They just can't get out of it. There's only cavitation and direct microjets will cause the most damage to the tendon, right? So, yeah, anyway, moving on. Fractures. Clinical success was shown, reported by several authors in the treatment of non-union fractures, pseudoarthroses, acute fractures of the tibia, femoral head necrosis, total hip revisions. All of these here, I'm going to tell you as a PTA, I'm letting the PT deal with this. If we're talking about actually acute fractures and trying to use this on that type of stuff, that's a PT. I'm at that point, you need consistent assessment of the area, and the PT should be doing that. We are not skilled enough as clinicians to assess an area consistently to make sure that we're not causing further damage. But there has been shown that it actually treats it. And again, this book, that most of the books that we have are going to be designed to not only help you guys, but also help PTs as well. So plantar fasciitis, low energy shockwave has been approved by the FDA for use. So this is now approved by the FDA. That's why it's starting to show up a little bit more in the area, because just like any other modality, the first thing that has to happen is it's got to go through FDA clearance, right? You would think that there's a long drawn out process for that, but if you ever actually see the process to get something FDA approved, you'd be surprised. They did some several randomized control trials, reported positive results. I can say from my experience that the best things I had results with Shockwave was plantar fasciitis and trigger points, especially trigger points in like the glutes, piriformis area like that, where I may not have enough force to get down and get the tissue. Does great things because it's going to allow that tissue to kind of pop up off the area and relieve the pain. Epicondylitis has been approved by the FDA as well. It's also been approved now over the FDA for trigger points as well, obviously. And the relief of pain and assessment of function have been used as an outcome measure. So here's the thing, it's just like any other treatment we're doing, right? So if you have epicondylitis and you're doing ultrasound and you're not getting any results from it, should you continue doing ultrasound? What do you think? No, right? It doesn't make sense. If you're not getting results, you need to change it. You may have, PT may have the diagnosis wrong, which happens, or we're just not doing the right modality for that patient. We've got to change up our thought process. And that's where we do come in quite a bit, because the PT is going to see them every so often for re-eval, but we're going to see them on the daily basis. If we see they're not getting anything out of it, there's no point to continue doing it, right? But with epicondylitis, there's great relief in pain. Now, again, initially when they get the treatment, it's going to hurt. And I've got a video of it just so you can kind of see what it looks like. Calcified tendonitis is another approved treatment. It is on schedule for approval with the FDA. It isn't quite yet. It's widely used in Europe and Canada, right? So what do you think it means when you have a calcified tendon? What's happening? It says it in it itself.
There's calcium deposits on the tendon.
Yeah, what's the tendon turning into? If you're depositing calcium, it's becoming what?
Calcium, hard.
Hard bone. It's becoming bone, right? You're getting heterotrophic ossification. It is becoming bone-like, right? And we know that if a tendon becomes bone-like, is it going to have the same tensile strength? Is it going to have that same plasticity and ability to stretch? Think about it. No. It's just not going to have that same stretch. So they're going to have the possibility of ripping that tendon greater. So this, especially like in Europe, they use this heavily for this. They know that especially like they've got calcification of the supraspinatus tendon, or even of the biceps tendon or triceps tendon. They can use this, and that cavitation will go in and break up that calcified area and allow normal healing to kick in, which means that tendon will lay down collagen. Now again, is that tendon never going to be as strong as it was previously? No. But at least with laying down collagen and scar tissue, it's not bone. So acoustic energy has been concentrated on an area about 2 to 8 millimeters in diameter. How do you think you're going to find the area that hurts with your patients? So say your patient's got plantar fasciitis. How are you going to find where it hurts?
Ask them to point to it.
You ask them to point to it, good. And then, Jesus, what else are you going to do to find it? I know you said you've done this, but I'm not going to call you out on it. Are you going to poke around a little bit? Yeah. Right? So if I have plantar fasciitis, I'm going to go, well, where does it hurt? They're going to go right here. So the next thing I'm going to do is I'm going to go down here and go, is it more here or is it more here? And I'm looking at their face. Oh, it's more there. Okay, that's it. Okay. I'm going to mark that area with a skin marker. And then I'm going to kind of palpate all along. That's why Dr. Johnson's teaching you anatomy, is because you've got to go be able to palpate down all those tendons, right? And all those muscles in that area to find where their sensitive areas are going to be, right? Where do you think, so you think about it, if this is the plantar surface of my foot, right? Where do you think a lot of my tenderness is going to be? Is it going to be in the arch portion of my foot, or is it going to be up towards my med heads, or is it going to be back towards my heel? Yeah, the arch portion, exactly, right? Because that's where that skin's getting pulled up and stuck down. So then when you curl your toes or something like that, everything's getting kind of snatched up and tight. Where you extend, a lot of times when they extend and dorsiflex, that's when they have a lot of pain with it. So they'll try to keep themselves kind of like this and almost what I call a claw foot to avoid the pain. We're going to get in there, we're going to palpate on it, right? You get up to that med heads, they're like, no, I don't have anything at those med heads, right? The metatarsal heads. And you come back, how about here? Oh yeah, that's it. Same thing with epicondylitis, right? We're going to get on there, palpate around, find those spots. Because if you look, 2 to 8 millimeters is not a large area. So if your patient's got a whole line of spots that hurt, we're going to go each of those spots slowly at a time and go down and do 1,000 to 4,000 shocks at about 1 to 4 pulses per second. What else is a term for pulse per second? There's another term for that. I almost seem to remember it. In physics, we talked about there's another term for pulses per second. You might deal with it. Okay, good frequency, which is measured in Not pain-free, but hurts. Exactly, good. Get it? Not pain-free, but hurts. No? Okay, fine. So we're gonna mark those areas down, and we're gonna treat the specific area that's needing treating. But let's say that I've got just a line and a strip running down maybe my third ray of my foot. You missed those jokes, right? Running down that third ray of my foot. And I'm gonna go in and send those sound waves in there. Would there be any point to me sending them out here if she has no pain? Well, no. It's just like any other treatment. We're gonna treat the area that needs treated and not go off and just because the patient's like, well, that felt good, go ahead and shock me on another part of my foot. No, we're gonna treat the area that they need treated, right? Treatment's gonna, it says last 15 to 30 minutes, but I've yet to encounter a treatment where it's more than maybe 10, because that's about the limit. They're gonna tap out at about 10 minutes. I can guarantee it. It's not comfortable. Sometimes we can use imaging devices, especially if they're doing the fracture, to coincide with the treatment. But again, that's going to be a PT because that's going to require evaluation. Anesthesia is not necessary. I like that we say this. Tell patients like, well, are you going to numb me up before this? Nope. We numb them up. We're not knowing if we're on the right spot, right? Same idea. When I broke my neck back when I was a teenager from a drunk driver, they put me in a halo. And for those who don't know what a halo is, it's probably the most uncomfortable device they ever can. Part of the halo is a ring, that's why it's called halo, that goes around your head that gets screwed into your skull, right? And when they said they were going to come at me with a DeWalt power gel, I was like, are you gonna numb me up or knock me out? They're like, no, we can't, because we have to make sure we don't go too deep with the screw. That made me feel comfortable. Same idea with this. We're not gonna numb them up because then we're not knowing if we're treating the right area or not treating the right area. That pain response is how we know we're treating the right area. We're gonna focusing on it, checking on them every about 200 to 400 shocks. If the pain's not reproduced, then the condition's not likely to respond. So if we mark all those little pain areas and we do the shockwave treatment, they're like, I didn't feel anything. Is that supposed to do something to me? Then it's likely not gonna relieve it. At that point, we may have something biomechanical wrong more than just tissue adhesion. Shockwaves are applied to the point. I just realized this has this weird like shadow effect on the text, and it really bugs me. Shockwaves are applied to the point of maximal tenderness at the lowest energy setting. So we want to do max tenderness, it's messing with my eyes, exactly. Max tenderness, low energy to start with, and then bump our energy up as we go along. It's just like E-stim, right? I heard Dr. O'Neill talk about it. It's not like you go in and you crank them up to 90 millivolts right off the bat. No, you slowly step it up, unless it's, Russian, and then I do crank it up pretty quick. But I started off slow because I don't want to overwhelm them with it. Same idea here. You want direct patient feedback. So that means you need them to be constantly telling you how it feels. And they'll tell you how it feels. A lot of times if you're doing plantar fasciitis, they'll be trying to crawl away from you. It's really uncomfortable. Jesus, what would you say your patients' experience are that have had it? Do they really love it? Jesus still awake? I don't think he's awake. Or he doesn't have to unmute his mic. I'm gonna go with unmute his mic. Intensity slowly increased to patient tolerance, right? So let me unshare this screen here and let me get the video brought up because I have like 2 quick videos, nothing major. Where are my videos at? Oh, there we are. All right. Can everyone see my screen? Yes?
Yes.
Okay, cool. Thank you.
Yes.
All right. So I've never tried the YouTube video with this, so let's see if we have sound. I'm not sure. We'll see. You guys had sound, so I probably should. I'm going to turn it down just so it doesn't blare you guys out right off the bat. The 2 main companies that release shockwave treatment machines are BTL, which is a German company, and Chattanooga, which is a German company owned by the Japanese. So I'm just saying most of them are produced in Germany. But this is their kind of introduction to their treatment. And I'll post links to these videos as well. That way you can watch it. Look at these star-studded actors. Dr. Ovreska would be mad with that. Adhesive capsulitis. All right, this was not what I thought it was. Oh no, there it is. Okay, it's just a lead in. So again, calcification, tendonitis, impingement is kind of what they're showing. This is the good old days of 360p television, not quality 1080p or 4K. Again, here are the clinicians palpating to try to find the area. And you'll find in overseas, a lot of massage therapists use this, not only just PTs and OTs. Oh, this is a horrible video quality. There's the coupling gel.
Why doesn't he have pants on?
Because it's a German video, that's all I'm gonna say. I don't know. I didn't notice that until you brought it to my attention, but thanks for bringing that to my attention. As you can see, it doesn't take a lot of force at all to do anything. She's just literally holding it in against the skin, and the machine, the sound head itself, is doing all the work. Yeah, so you saw theirs. Where's the Chattanooga has a decent one that was, this one's a little bit better and a little bit better quality. I think they have pants on. Can you guys hear that?
No, no sound.
No sound.
All right, well, we'll use this just for an example, and then let me get my drawing tools. That still would be good to show. So obviously this is a 2-channel unit. How do you know this is a 2-channel unit? Because it said channel 1 and channel 2, right? So you have your sound heads, just like you have sound heads with ultrasound. And there's our conduction gel. I want to pause that right there. Hold on. Oh, pause, not draw. So I wanted to come back here because I wanted to get a good picture of the sound head. So when you're looking at the sound head here, if you can see it, the sound head has a couple parts that are important. So now let me get my draw on. So obviously we've got a trigger right here. That's what's going to activate the actual sound head. And then you have the piston and the piezoform crystal up here. So the electricity is being driven down in here to the crystal, right? The crystal starts vibrating and starts sending sound waves out. And again, just like with ultrasound, you don't want to hit that trigger until the head of this machine is against the patient and the coupling agent. On top of all that happening, let me get a different color here. This is a good way to kind of demonstrate it. There's a hydraulic piston in here. So it's a fluid-filled cavity. And when that happens, it pushes down. And when that pushes down, the tip of this unit actually pops out and back in. So that's what causes that hydraulic action, right? And then it's also going to send a slight magnetic pulse to go along with it. So there are 3 different forms of sound that's going to be transmitted. Wow, that looks really scary, the drawing I did. 3 different sounds that are going to be coming out of the tip of this ultrasound. I was in German hospital once, it was like a horror movie. It's great. So there's 3 different sound waves coming out of. There's a piezoelectric sound wave, there's an electromagnetic, and then there's also a hydraulic or electrohydraulic. All of those are coming in and creating this really, really intense or really loud, not loud in loudness, but loud as intensity sound wave that's going to go in and refract off that tissue and release it. That's my quality drawing. That's the extent of my drawing for the day. Since you guys don't have sound, I'm just going to post the links to the video because that way you guys can watch the videos on your own because I don't want to make you sit through a video you can't hear. She explains it pretty well. There are a couple of them that I have here. But the main idea of this treatment is, and it's using sound waves that are a little bit more intense than your ultrasound sound waves to go in and cause extreme cavitation and a little bit of tissue damage in order to break up that chronic inflammation cycle and get the patient into a proliferation cycle and get them to heal, right? You remember those cycles of healing? Remember going through those? I know you've gone through them with Dr. Sokel. Those are going to come into play almost every semester. I can guarantee it, especially when we get into wound care. The other group just went through wound care with me and they're like, oh, I thought we could forget these. Nope, right? That inflammation cycle, proliferation, right? Remodeling, maturation, and scar formation, all of that comes into play again as we progress through this program, because we want to keep the patients out of being stuck in chronic inflammation. If they're stuck in chronic inflammation, they typically don't get better. And then they end up with all kinds of problems that go along with chronic inflammation, right? There's a lot of theories that show that fibromyalgia might be a patient that's stuck in that chronic inflammation cycle and can't get out of it. But again, main treatments for this one you're going to see here in the United States are going to be trigger points. Like again, especially trigger points that are a little harder to get to. How many of you have ever had a trigger point treated? Not with this, but just in general. Have any of you had trigger points or heard? What are trigger points? Does anyone know what a trigger point is?
I actually don't really know what it is.
So trigger points are little areas of your muscles, and there's a lot of theories that show what they are. You know, some of the theories say it's a little area of localized bubbled lactic acid. Some of it say it's a little area of bound down adhesion on the muscle itself. Some say it's a micro tear that hasn't healed. But a lot of times with trigger points, you can find them, especially if you go back and you crawl along your traps, you can usually find trigger points. And how do you know you found a trigger point? When you touch it and all of a sudden you're like, okay, that kind of hurts. A lot of times you have them in your lower traps going towards that inferior angle of your scapula, or right along that scapular spine. You'll also have a lot of trigger points. There's more in the subscap and those areas, but that takes a little bit more digging to get to. But these trigger points bind down, and when they bind down, it makes patients' movement uncomfortable. And so we can use this to kind of break up those trigger points and relieve their pain long term. We can also use this on plantar fasciitis, like I said, which is nothing more than really giant amounts of trigger points plus inflammation.
So, Mr. McKeever,
Yeah.
So trigger point is just a little area on a muscle that kind of hurts?
Yeah, it kind of hurts. And it's very nodule-like. You usually can feel it. And when we do this, so when we do Dr. Ovreskin will do a soft tissue mobilization lab with you in 4th semester. And we're going to palpate for trigger points. That's what she's really good about teaching how to do palpation for trigger points. That's why you guys have to know all of your muscles, right? Your origins, insertions, actions, and everything like that, because you have to know if the patient's got a problem in their mid-trap, how to know where those borders of the mid-trap are and how to palpate the whole length of it. At
Is
that
it
point,
chronic?
what'd you say?
Oh, sorry. Is it chronic?
It can be. Yep. I have a chronic trigger point at my inferior angles on both my, they're everywhere. Exactly. And massage therapists treat them quite frequently. I have 2 chronic trigger points right at the inferior angles of my scapula, and they're just there constantly. I can get them released, and 2 days later, probably from the way I sit.
Yeah, they're hard to miss. You could just press pretty much in any muscle and you'll be on one.
Oh yeah, you'll find one. You know, calves especially are really good at finding trigger points in those big gastrocs. Sometimes in tibialis anterior you can find some.
Extensors are really good too up by the condyle, the condyle.
And up in the subscap or sub-occipital region as well, you can find them. But they're just in a localized area of the muscle not functioning properly. And so we're going to relieve those. And honestly, when you release trigger points, and you can release them by manual therapy, meaning literally with trigger point release, you're going to put your fingers on that trigger point, hold it, and you'll feel it kind of just pop. And then you move on to the next one. You hold it down for 3 to 5 seconds, and it's uncomfortable to the patient. I know Tyler can speak to this. The patients really don't like the pressure, but they like the relief that comes along with the pressure.
Some love it, some hate it.
Yeah, I really don't like it. It's really, I get kind of testy about it. But I love doing that to patients though. Does this hurt? No, just kidding.
Yeah, they love it.
But then you have plantar fasciitis, which is nothing, honestly, when you look at it, plantar fasciitis looks a lot like a giant area of trigger points. It really does. And then of course your epicondylitis, right? Epicondylitis are where those condyles get stuck in that inflammation cycle and they're inflamed. All of those are valid treatments right now for shockwave therapy. We're looking at calcified tendonitis that still hasn't passed through FDA approval yet, but once it does, it'll be coming out as well for treatment here in the United States. The downside to Shockwave, it is painful. It's uncomfortable. You have to be trained in it. This would be one, and I'm not going to pick on Jesus here. This would be one modality I would never want a tech doing. I'm sorry, I wouldn't. At least as a PTA, and I don't know if Dr. O'Neill would chime in as a PT, this would be one that I do not want a tech doing. Because you can cause more harm to the patient than helping them. Same thing with laser and ultrasound. You really could hurt the patient if you don't know what you're doing. And I remember when we talked about this, we talked about e-stim and ultrasound with you guys at our techs when I was doing physics, and you're like, oh no, we just do whatever the settings are. You're now learning what's the difference between just doing the settings and being a skilled clinician. There's no way I can train you on this, send you out in the field, because each machine is so specialized. But what you do need to know about this is it works through cavitation, just like ultrasound. It's piezoelectric, hydroelectric, and magnetoelectric, or electromagnetic. There we go, I can speak today. And it's used primarily in the United States for treatment of condylitis or epicondylitis, right? And for trigger points and for plantar fasciitis. Those are the main things I want you to be focused on here. Are there any questions that I can answer about this? I said I'll post the videos, which do give a little bit better kind of an idea what it looks like when you can watch it and listen to the lady. And I don't know if I'll post the one with the guy that doesn't have pants now that I saw that. Kind of creepy. Any questions?
I actually do have a question, and if
Awesome.
you answered, I apologize because I had to step away. Everybody in my house went crazy at the same time. I noticed on one of the slides it said jumper's knee, and what was it, patellaropathy or something. What is the difference between that and like patellar tendonitis? Is there a difference, or is it just interchangeably?
Well, it just depends upon the method of injury, if that makes sense, right? So patellar tendonitis is going to be that patellar tendon being stuck in that inflammation cycle, almost like an epicondylitis.
Okay.
Right? Where jumper's knee is usually more of an acute injury.
Okay.
That's something that's kind of, now could jumper's knee lead to patellar tendonitis down the road? Sure.
Okay.
So could Osgood-Schlatters disease, which is really common with boys, right? Or PFPS, patellofemoral pain syndrome, is common with women.
Okay.
Right? So any of those can lead to that. And we get into that itises, that's when we're thinking about getting stuck in that chronic inflammation cycle.
Okay.
And, you know, are they going to present pretty similar? Yeah, they're pretty much going to present very similar.
So is one more painful than the other? I mean, I know they're chronic, but on a pain scale, is it different?
Honestly, I mean, not really. I mean, they're all going to present. And again, pain is relative, right? And this is true, right? Because sometimes your relatives are painful. Pain is relative to the person. You know, when I come in and I'd say that I'm a 6 out of 10, you know, my 6 out of 10 may be a 10 out of 10 for somebody else. So it's going to be relative to that person and how they've experienced pain previously. Okay. That's the main thing. Even epicondylitis to me, it annoys me. I know how to treat it. You know, there's some ice massage. It'll resolve as long as I stop doing whatever caused it. But for some people, that epicondylitis is crippling.
Yeah.
So it just depends upon how they experience pain. And we're going to talk about that. We're going to do a whole lecture on that in semester 5 on pain neuroscience education, about rethinking about the way we look at pain and stop looking at pain as a part of the body hurting and start thinking about it as the brain hurting.
Okay. Very cool. Thank you.
Yep. Anything else?
Can I give a little?
Yeah, give your little spiel, please.
If you look at the root of apathy, okay, apathy is really just a disorder. So exactly what Mr. McKeever says. So tendinopathy is a disorder of the tendon. When we talk about tendinitis, it's an acute inflammation. Usually though, it's an acute on chronic, meaning I know I have had, if I go and do a bunch of box jumps right now, okay, I will probably get jumper's knee and or knee pain from that. If I ice it, do my ultrasound, get everything I need to do, but I don't strengthen the muscles, I don't improve my technique, guess what's probably gonna happen the next time in a month or two I decide to go do box jumps? I'm probably gonna re-swell that up. So I'll get another tendinitis flare up. If they go in and do an ultrasound imaging of that patellar tendon, they might see some because it's been chronically happening to me over and over again. Does that make sense, guys? So opathy is the actual, it's a generic suffix for disorder. The actual itis means inflammation. So, yeah. And you can have, like he said, the tendonitis for the elbow, that some of you have it. You know it comes and goes, unfortunately, more frequently than you want. If you don't treat the underlying cause, whether it's posture, weakness of your, scapular muscles, if we're talking about lateral epicondylitis, technique of whatever it is you're doing, you're gonna just keep injuring it over and over again. So. And then my 2-second spiel about shockwave therapy, I will be honest, you guys know I'm not an outpatient person per se. When I have done it, it's been pro bono, so we don't have any fancy modalities to use. When I was in Spain last year, I have a tendency, if I don't wear my proper footwear, to get some plantar fasciitis, but I have orthotics. For some reason, the orthotics did not make it in the suitcase. I thought I would be okay, but anybody that's ever traveled into Europe knows you take, 15,000 steps on minimum by day 3. And keep in mind, I was there for work. I was there as an international speaker, as well as taking 8 PT students along with another faculty at this, we were doing a university exchange. So it wasn't like I was just there to see all the sights and drink the wine. I was supposed to be doing stuff with them. And it was painful. And thankfully the program director there had done some research and showed me the shockwave therapy. And let me tell you, it is mind-blowing how quickly I got relief. Not only was I able to go to the local pharmacia though, and also buy the cheap, like Dr. Scholl's Are You Gelin to help, but the dramatic improvement, literally within 2 days, I had a couple treatment sessions with him, and within 2 days I was manageable. I thought I was going to have to cut the trip short, drink more wine, all these terrible things that would have to, accommodate, but it actually was really helpful. So I'm a fan of it. I also, for what Mr. McKeever said in terms of tech using it, I don't think any tech should feel bad if they are asked to use it. I don't want you to put yourself in a position where you get fired. I just want you to think, if it was my license, when I'm licensed, would I delegate this to somebody? After you know the science behind it, what Mr. McKeever explained to you, would you want an unskilled, unlicensed person applying this modality? Would you want it applied to your mom, your dad, your grandpa, your children, unless they have a really working knowledge of what the risks are for this machine? My answer would be no.
Great feedback. I wasn't trying to jump on anyone that was tech. Please don't think. I know I joke about it, and you do what you've got to do to get through. But just I often like to think of it as, would you want a CNA doing your opening for your surgery? And probably not. Doesn't mean that CNA is not skilled, but that's just not in their wheelhouse, and they haven't been properly trained on how to do it. So this is why we train you. You're trained as a skilled clinician, and you will be licensed in doing these modalities. But at the same time, right, exactly. Thank you, Kaylee. But at the same time, understand, even as a PTA, when I first saw this, we went over it, literally, it was in the back of our book, and that was all I covered on it. And so, when I first moved to a clinic that did this, I had to get fully trained on it. I couldn't just say, oh yeah, I can do shockwave. Sure, I could have injured the patient. I had to go home, watch a few videos, break out the manual, read through the manual. And I spent a lot of time looking at the physics of it. And to me, that was what really hit me, is I was like, wow, I understand how the physics of this works. And that's why I was really a proponent of it. So make sure that no matter what you're doing, it doesn't matter if you're a tech or if you're a PTA, if you're not skilled in doing it, be careful, because you can hurt a patient. And we don't ever want to do that. Any other questions I can answer? If not, I am finished, Dr. O'Neill.
Okay. Can I make a quick announcement?
I'm going to stop the recording first, and then we can make an announcement. How's that sound?